Okay guys, my name is Dr. Khan. I am an anesthetist and intensivist. We'll be dealing with this topic of anesthesia, starting with this topic, which is called as airway devices. The airway devices that are used in anesthesia techniques. Okay. So guys, we are starting with this airway device, which is called as LMA, laryngeal mask airway. Laryngeal mask airway. This airway device that you see on the screen is called as laryngeal mask airway, LMA. Right. What is the indication of this LMA, guys? What is the indication? But before going to the indication of LMA, this is the laryngeal mask airway, and here is this device called as endotracheal tube. These are two devices. For airway, you are having laryngeal mask airway or endotracheal tube. You guys think and tell which is a definitive airway. Which airway device is regarded as a definitive airway? Is laryngeal mask airway a definitive airway or endotracheal tube a definitive airway? Which device is a definitive airway, guys? Definitive airway means what? An airway device by which you are 100% sure that you are only ventilating the lungs, and the airway device that prevents aspiration. What is that? It is always the endotracheal tube. With endotracheal tube, you are 100% sure that you are only ventilating the. So my question to you was, which is the definitive airway? Always remember, guys. Okay, repeat from here. Always remember the definitive airway is endotracheal tube. Why endotracheal tube is a definitive airway? Why? Because imagine this is the trachea. You have put the endotracheal tube inside the trachea. Now when you ventilate, you are 100% sure that you are only ventilating what? You are only ventilating the lungs. You are only ventilating the lungs, right? That's why endotracheal tube is a definitive airway. And if at all the patient regurgitates, will he aspirate? Will the regurgitated material go inside the lungs? It won't go inside the lungs. Why? Because this endotracheal tube cuff is preventing aspiration. Hence, ET tube is regarded as a definitive airway. What's not a definitive airway, guys? LMA, laryngeal mask airway. Laryngeal mask airway is not a definitive airway. It is never a definitive airway. Why it's never a definitive airway? Why? Because laryngeal mask airway fits into the supraglottic area. It fits into the supraglottic area. Hence, it is also called as supraglottic airway device. It is also called as what, guys? Supraglottic airway device. When you put this laryngeal mask airway into the patient's mouth, it fits into the supraglottic area. Then you connect this laryngeal mask airway to a breathing circuit and you ventilate the patient. Where will the gas go? Where will the ventilated gas go? The gases will go into the trachea as well as into the esophagus. Imagine if the patient is full stomach, what will happen? The moment the gas goes into the esophagus, patient will aspirate. So LMA causes aspiration in full stomach patient, right? Due to this reason, LMA is not a definitive airway. The definitive airway is always what, guys? Endotracheal tube. Endotracheal tube. And we know the reason why it is a definitive airway. Anyways, we are talking about this LMA. If LMA is not a definitive airway, then why are we using this? First of all, LMA. LMA is a laryngeal mask airway. It is also called as Bain's airway. It is also called as what airway? Bain's airway. R is silent. Bain is the same guy who did modification to type D circuit. Hence, type D circuit was called as what circuit? Bain circuit. So anyways, LMA is also called as what airway, guys? Bain's airway. Bain's airway. It was introduced by Bain, right? Now, this is a device that fits into the supraglottic area. Will it prevent aspiration or will it cause aspiration? It will cause aspiration. So, the prerequisite, the main prerequisite, before going to the indication of LMA, we should know the prerequisite. The main prerequisite for the LMA is what, guys? The patient should be empty stomach. Patient should be empty stomach. Then only you go for LMA. But what is the indication of LMA? Prerequisite is empty stomach. That is a condition. But what is the indication of LMA? in which patient you will put an LMA. What's the indication of LMA, guys? In which patient you will put an LMA? LMA is usually indicated for what patient? LMA is indicated for what patient, guys? If, imagine guys, I am going for endotracheal intubation. I take laryngoscope, I introduce laryngoscope into the patient's mouth, I lift the tongue, and now I am not able to see the vocal cords. I get panicked. What to do now? I am not able to see the vocal cords. I can't go for blind intubation. I will remove the laryngoscope. While doing laryngoscopy, the patient will develop desaturation. I'll remove the laryngoscope and I'll go for a bag mask ventilation to this patient. But imagine your bag mask ventilation is also not that much helpful. In that scenario, what will I do? I will go for an LMA. If my bag mask ventilation is not adequate to improve its saturation, I'll go for laryngeal mask airway, a temporary airway device. Okay. So guys, the main indication for LMA is what? Difficult intubation or failed intubation. Difficult or failed intubation, you can go for LMA. Failed intubation, you can go for LMA. Apart from that, one more indication for putting an LMA is what? One more indication is what? If the patient is posted for minor surgery. If the patient is posted for minor surgery, you can go for LMA. You can go for laryngeal mask airway. That is the indication of LMA. That is the indication of LMA. After the indication, what we need to remember in the LMA is what? What is the advantage of using this LMA? Before going to the sizes and all, what is the advantage of using this LMA, guys? Come on. What is the advantage? Advantage is, remember, LMA is a device that is very easy to put. You do not require laryngoscope and all. Even though you guys have not ever, you did not ever use LMA, it's my guarantee that you can put an LMA easily in a patient. Why? Because it does not require any skills and all, guys. You don't have to learn about this. I'm not telling that you guys are not skilled. I'm just telling that it doesn't require any skill to put an LMA. But for endotracheal intubation, you have to take laryngoscope, lift the tongue and put the tube. For LMA, take the laryngeal mask airway, put it blindly into the mouth. It will fit into the supraglottic area. Take the laryngeal mask airway, hold the laryngeal mask airway in a pen-like fashion. Introduce the laryngeal mask airway into the patient's mouth. Introduce it till what time? Till you feel the resistance. Till you feel the resistance. Once you feel the resistance, stop over there. That means it is in the supraglottic area. Supraglottic area. Then you don't have to advance it too much. Okay? So advantage of using LMA is what? The main advantage is it is easy to put and does not require any laryngoscopy and does not require any laryngoscopy. It's easy to put that it does not require any laryngoscopy. Okay? And it does not require any muscle relaxant also. Doesn't require muscle relaxant also. Right? That is the advantage of using the LMA. But only it might require what? An IV induction agent. Which is the IV induction agent of choice for LMA insertion? Propofol. IV induction is required, that is propofol. That is propofol. We know the advantage, we know the indications. We also need to know about the contraindication of LMA. In which patient LMA should never be put. First is a full stomach patient. Why, sir, in full stomach patient, why it is contraindicated? Why? Because in full stomach patient, if I put an LMA and if I ventilate the patient, what will happen? The gases will enter the esophagus also and the patient will aspirate, right? So it is contraindicated in full stomach. Apart from full stomach, LMA is also contraindicated if you have blood in the oral cavity. Why, sir? Why blood in the oral cavity is a contraindication? Why? Because if there is a blood in the oral cavity, if you put an LMA, you are pushing the blood into the lungs. that can cause aspiration. So blood in the oral cavity is a contraindication, and cancer of the oral cavity. And cancer of oral cavity is also contraindication. If the patient is having a mass in the oral cavity, can you put an LMA? If you want to put also, you can't put. Why? Because it won't go. Any cancer in the oral cavity is also a contraindication for LMA, right? So these are the contraindications. Indications we know, advantages we know, contraindications we know. Now we need to know the size of LMA. Size of LMA. What size LMA should we use in children and what size LMA we use in adults? Basically, the size of LMA depends on the weight of the patient. If the weight of the patient is less than 5 kgs, we use size 1 LMA. We use size 1 LMA. If the patient's weight is 5 to 10 kgs, 1.5. Again guys, two sizes are very, very important. Size 1 is used in less than 5 kgs, यानी कि basically size 1 is used in neonates. Size 1.5 is used in infants. You have to remember this. Size 1 and 1.5 is used in the infants. 1 is used in neonates, 1.5 is used in infants. Neonate यानी कि first 28 days after birth, यानी कि patient's weight will be less than 5 kgs. In infancy, the weight will be between 5 to 10 kgs. So, size 1 for less than 5, size 1.5 for 5 to 10 kgs. In adults, we use size 4 and size 5. Size 4 LMA is used for 50 to 70 kgs person. Size 5 LMA is used for 70 to 100 kgs person. Size 4 is used for 50 to 70 kgs adults, whereas size 5 is used for 70 to 100 kgs. This is the most commonly used LMA in adults. In adults, right? This is regarding what? This is regarding the laryngeal mask airway. Guys, remember, is the laryngeal mask airway preventing aspiration or causing? It is a causing aspiration. Laryngeal mask airway is a temporary airway device. If you fail in intubation, if there is a difficult intubation or minor surgery, you go for it. Advantage, it is easy to hold, it is easy to put. No laryngoscopy, no muscle relaxation, but only IV induction agent will be required. Size 1 and 1.5 is used in infants, yani 1 is used in neonates less than 5 kgs, 1.5 is used in 5 to 10 kgs. Whereas in adults we use size 4 and size 5 LMA. So this is regarding the laryngeal mask airway. We'll start from here. So this was regarding laryngeal mask airway. Is it preventing aspiration or causing? It causes aspiration. Hence, a vague attempt to modify this LMA was done. Guys, look over here. This is the normal laryngeal mask airway which I was talking you about. Okay? Right? There was a vague attempt to modify the LMA. This modified LMA was called as Proseal LMA. What modification that they did in the Proseal LMA? They added two lumens. One is the tracheal lumen, other is the esophageal lumen over here. Proseal LMA, there was two lumen LMA. What modification was done? After putting the LMA through the esophageal lumen, they were introducing the Ryle's tube, and this Ryle's tube was going into the esophagus, and the one end of the Ryle's tube was attached to the suction catheter. Through that suction catheter, they were sucking out or deflating the gastric contents so that the patient should not aspirate. But still, is it preventing 100% aspiration risk? No, sir. Still, there is risk of aspiration. So, whether it is Proseal LMA or whether it is a normal classic LMA, both are causing aspiration, right? Both will cause aspiration. Proseal will have a less risk of aspiration, right? Proseal LMA is a modified version of an LMA where an extra lumen called as esophageal lumen is given, through which we are passing the NG tube or the Ryle's tube. The NG tube is nasogastric tube. Okay? Right. This Proseal LMA, just look over here guys. Right. This Proseal LMA is having an additional tube through which NG tube is passed. What is it? NG tube. The nasogastric tube is passed. into the esophagus. It is used for gastric deflation to prevent the aspiration of gastric contents. The tip of this LMA is placed at the upper part of the esophagus. Upper part of the esophagus, right? This is a Proseal LMA. So that was regarding the LMA, guys. LMA is laryngeal mask airway. So in the airway device, my first question was, what is a definitive airway? LMA or ET tube? The answer is what, guys? Always ET tube is a definitive airway. Why ET tube is a definitive airway? Why? Because ET tube fits into the trachea and you are 100% sure that you will be only ventilating the lungs. You are only ventilating the lungs, right? And ET tube, with ET tube, there is no risk of aspiration. There is no risk of aspiration. But with LMA, there is a risk of aspiration. So we are starting with what, guys? We are starting with this endotracheal tube. Endotracheal tube. Now in this endotracheal tube, you can see first introduction of endotracheal tube, guys. Endotracheal tube was introduced by a guy called as William McEwen, but it was made popular by a guy called as Evan McGill. William McEwen did the first endotracheal intubation, but it was made popular by Evan McGill. Why? Because William McEwen was a timid guy. He did endotracheal intubation, but he was very shy and introvert person, right? So Evan McGill, he made the endotracheal intubation popular amongst the anesthetists and the physicians. Now, there are two kinds of tubes. You can see the two tubes over here. One is called as red rubber tube, and other is called as the PVC tubes. It is not white rubber, it is PVC tube. PVC means polyvinyl chloride tube. Polyvinyl chloride tube. Now guys, you need to tell me which tube should be used. Which tube are we using now? Are we using the red rubber tube or are we using the PVC tube? Come on guys, what is the tube that we are using nowadays? Think and answer, red rubber or PVC? Right? As yes, most of you might be thinking PVC tubes are red rubber tubes. The color is also very oddly looking and all. It looks like very old. So yes, but the reason why don't you use red rubber tube is what? It's not the color. It is basically the reason is what? Just look over here. This is the reason. What is this, guys? What is this of the PVC tube? This is the cuff of the PVC tube. The cuff is the reason of the PVC tube, right? How is the cuff? Why aren't we using, the cuff is the reason of the red rubber tube. Why don't we use the red rubber tube nowadays? The reason is the cuff. Why? Because the cuff of the red rubber tube was having very high pressure even at low volumes. High pressure and low volume. Due to this high pressure, what was happening? After doing endotracheal intubation, we were inflating the cuff. As the cuff was inflated, as the pressure inside the cuff was very high, most of the patients after surgery were complaining of what, guys? They were complaining of severe pain in the throat, severe pain in the neck region. When we examined the trachea, they were developing pressure necrosis caused by the red rubber tube. This red rubber tube will cause pressure necrosis in the trachea. Hence, are we using these tubes? No, we are not using red rubber tubes which are high pressure, low volume. Red rubber tubes were what, guys? High pressure, low volumes. Are we using these tubes? No, we are not using this. Instead of that, we are using PVC tubes. Nowadays, we had made PVC tubes cuff what? The cuff of the PVC tube is low pressure even at a high volume. Low pressure even at what volume? High volume. Red rubber were high pressure, low volume, whereas PVC tubes are low pressure, high volume. They are low pressure, high volume. In this PVC tubes, what we need to remember, what are the parts of the PVC tubes? What are the parts of this PVC endotracheal tube, right? So we are discussing about the PVC tube which is commonly used. First of all, guys, you need to understand there are two types of PVC tube. One with cuff, which is called as cuffed PVC tube, other without cuff. Now guys, think and answer. In which person will you use a cuffed tube and in which person will you use a uncuffed tube? Person means what? I'll give you an example. There is a child and there is an adult. In which person will you go for cuffed endotracheal tube? Cuffed means what? With cuff. Uncuffed means this is a trachea and you are using this tube and it is fitting into the trachea. It is fitting into the trachea. Remember, uncuffed endotracheal tube is used in children. Why? Why? Because the diameter of the tube corresponds to the diameter of the trachea, whereas adults are having a large tracheal lumen and this tube will not fit. So, in adults, what is the tube that we use? Cuffed tube. Nowadays, we are also using cuffed as well as uncuffed tube in children. We are also using cuffed tube in few children. Okay, but still remember, uncuffed are used in children, cuffed are used in adults. Okay, so I told you the tubes can be either cuffed or uncuffed. What are the parts of this endotracheal tube? The first part of the endotracheal tube, you can look over here, the first part of the endotracheal tube is what? This end of the endotracheal tube, which is called as a bevel end. This part is called as a bevel end of the tube. The second part of the endotracheal tube is what? This is the cuff of the tube. Here is the cuff of the endotracheal tube. The third part of the endotracheal tube is two markings. You see two markings on the endotracheal tube. Okay, I'll tell you the importance of two markings. Next part of the endotracheal tube, you can see this pipe over here, right? This is the cuff inflator. This is called as pilot. This part is called as pilot. And the last part of the endotracheal tube is what? Connector. Here is the connector. Once again, guys, we are discussing about what? We are discussing about the parts of endotracheal tube. What are the parts of endotracheal tube? First is the bevel end of the tube. Second is what, guys? Cuff of the tube. Then there are two markings, black markings on the tube. Then there is a pilot through which we can inflate the air. Okay? Then there is a connector. These are the parts of the endotracheal tube. Now, guys, focus on this point. In between the bevel end of the tube and the cuff, do you see a small opening? This is the bevel end, right? Here is the cuff. Do you see a small opening? One more opening over here. When one opening is given at the bevel end, one more opening is given just between the bevel end and the cuff. What is that opening called as? Murphy's eye. Why is that opening given? When you were having one opening over here, why is one more opening given over here? Why? Because if your endotracheal tube, imagine this is the endotracheal tube. What is the importance of Murphy's eye? Murphy's eye, why it is given? Why? Because if one end of the tube, if this end of the tube is getting blocked, patient can be ventilated through this end. This end is what? Murphy's eye. Patient can be ventilated through the Murphy's eye. So basically it is the route for providing alternate ventilation. It is a route that provides alternate ventilation. So that is regarding the importance of Murphy's eye. Coming to the two marks of endotracheal tube. I told you there are two marks of the endotracheal tube. But before going to the mark, there is a cuff. How is the cuff of the PVC tube? The cuff of the PVC tube will be high pressure or low pressure? Come on, guys, high or low? Obviously, low pressure. Low pressure, high volume. Low pressure, high volume cuff. The pressure inside the cuff is how much? 15 to 22 mm of Hg. The pressure inside the cuff is how much, guys? 15 to 22 mm of Hg. It is a low pressure, high volume cuff. Now, guys, regarding after cuff is the two markings. Why are the two markings given on the endotracheal tube? But before going to the markings, the question to you is, if this is a trachea bifurcates into the right and left bronchus. ठीक है? So when you are placing an endotracheal tube, where will you place it? Will you place it on the carina? Remember bifurcation of the right and left bronchus, that point, this point is called as what? Carina. This is called as carina. Will you push the endotracheal tube on the carina? No. Whenever you are placing an endotracheal tube, you place the endotracheal tube 3 to 4 centimeters above the carina. How many, guys? 3 to 4 centimeters above the carina, so that when you are ventilating the patient, both the lungs should be adequately ventilated. Both the lungs should be adequately ventilated, right? So whenever you are placing the tube, it should be 3 to 4 centimeters above the carina. But how will you come to know that you are 3 to 4 centimeters? Your tube will not tell, no, I am 3 to 4 centimeters. How will you come to know? While doing laryngoscopy, you lift the tongue, right? You lift the tongue, you lift the epiglottis, you see the vocal cords. Once you see the vocal cords, under vision, you have to pass the tube. The importance of two markings is what? One mark goes inside the vocal cord, other should be visible to you during laryngoscopy. The other should be outside the vocal cord. If the other mark, yani one is going inside, the second mark should be outside, it should stay outside the vocal cord. That ensures that you are 3 to 4 centimeters above the carina. That ensures that you are in the correct position to ventilate the patient, right? So marking, there are two markings on the endotracheal tube. One mark stays inside and one mark stays outside the vocal cords. One mark stays outside the vocal cords, right? Marking say you can easily determine the position of the tube. Okay? So after markings, now guys, connector. Last part is the connector. So once again I told you, cuffed endotracheal tube is used for adults, whereas uncuffed endotracheal tube is used for children. Uncuffed endotracheal tube is used for children. The pressure inside the cuff is 15 to 22. How is the pressure? Low or high? PVC tube always low pressure, high volume. Low pressure, high volume. PVC tubes are it's already given. It is low pressure, high volume. Red rubber tubes were high pressure, low volume. High pressure, low volume. So guys, in adult male and an adult female, in an adult male and in an adult female, what is the tube that we are using? For adult male, the tube that we use is 8 and 8.5 size. 8 and 8.5 size. Whereas for adult females, we are using 7 and 7.5. Okay? Guys, remember, we are talking about the size of the ET tube. There was a question stating that an anesthetist ordered for an endotracheal tube of 8 number. What does that 8 number means? Is it the length of the tube, guys? No, sir, it's not the length of the tube. What is that? You can see over here, it is basically the internal diameter of the endotracheal tube. It is what, guys? The internal diameter of the endotracheal tube that determines the resistance. That determines the resistance through which the endotracheal tube passes to the trachea. That is very, very important. Size of endotracheal tube is basically the internal diameter of the tube. Size is the internal diameter of the tube. I told you an adult male 8 and 8.5, female 7 and 7.5, right? Remember, size is the internal diameter. Size is basically internal diameter, not the length. And this internal diameter determines the resistance. It determines the resistance. In children, what size endotracheal tube we use? It totally depends on the age of the child. If the child age is less than 6 years, we use this formula, age by 3 plus 3.5. Age by 3 plus 3.5. Whereas if the child age is more than 6 years, we use this formula, age by 4 plus 4.5, right? In low birth weight, in neonates, we are using 3.5 and all, okay? But remember, whenever you are placing an endotracheal tube, where will you position, guys? You position the tube on the carina or above the carina. Always remember, you position the tube how many centimeters above the carina? 3 to 4 centimeters above the carina. When you place it 3 to 4 centimeters above the carina, you will be sure that you are ventilating both the lungs. Okay, so that's regarding what? That's regarding the endotracheal tube. Now guys, remember, how will you do an endotracheal intubation? How will you do an endotracheal intubation? For endotracheal intubation, the device that is required is this device. What is this device, guys? This is called as laryngoscope. This device is called as what? Laryngoscope. There are two laryngoscope blades available. One is a straight blade laryngoscope, which is called as Miller's laryngoscope. Other is a curved blade laryngoscope, which is called as Macintosh laryngoscope. What laryngoscope are we using in adults? In adults, we commonly use what laryngoscope? Miller's laryngoscope. Whereas in children, we use Macintosh. Sorry. Okay, just cut that part. So, start from here. In laryngoscope, we are having two laryngoscope blades. One is Miller, other is Macintosh. Miller is used in pediatric patients, whereas Macintosh laryngoscope is used in adults. Why is Miller's used in pediatric patient? Miller's is a straight blade laryngoscope. Why it is used in pediatric cases? Why? Because children have a large epiglottis. Children have a large epiglottis that can be easily lifted with a straight blade. Hence, in children we are using what? In children we use the Miller's laryngoscope. Whereas in adults we can use the curved blade laryngoscope called as what? Macintosh laryngoscope. So remember guys, for endotracheal intubation you will have a laryngoscope. You held this laryngoscope in your left hand. But before taking the laryngoscope, first take the position. Position of the patient is very important. What is that position called as? Sniffing morning air posture. This position is very important. During laryngoscopy, you have to first, before laryngoscopy, you have to make this position, make the patient lie down in what position? Sniffing morning air posture, right? You keep the pillow beneath the neck of the patient, you will get this position. There is flex, basically what is this sniffing morning air posture? There is extension at the atlanto-occipital joint and flexion at the neck. Very, very important. There have been an MCQ asking you about where is the extension and where is the flexion in sniffing morning air posture. In sniffing morning air posture, there is extension at the atlanto-occipital joint and flexion at the neck. This position is called as sniffing morning air posture. Sniffing morning air posture. After making the patient lie down in this position, what we do, we take a laryngoscope. I told you there are two kinds of blade. In adults, we use Macintosh laryngoscope. So we take this laryngoscope after making the patient lie down. So you can look over here, as we have made the patient lie down, we take this laryngoscope in our left hand, we introduce the laryngoscope from the right side of the patient's mouth, right? We introduce the blade till your blade reaches the level of vallicula. Vallicula is a depression beneath the tongue. Once your blade sits into the depression, you stop over there. Now what we need to do? Now we need to lift the tongue. How will you lift the tongue? Will you lift the tongue with the help of wrist movement, or will you lift the tongue like this? Like this means the blade just look over here, you are lifting the tongue so that the pressure of your handle is towards the roof. Which manner will you lift the tongue? You lift the tongue so that your pressure of the handle should be towards the roof, not by wrist movement. Why not by wrist movement? Why? Because the handle of your blade, the handle of your laryngoscope is lying on the patient's teeth. If you lift the tongue with wrist movement, you will easily break the teeth of the patient. You will easily break the teeth of the patient. So remember guys, you take the laryngoscope in your left hand, you introduce from the right side of the mouth and you advance the blade till you reach the vallicula. Once you reach the vallicula, you lift the tongue. Once you lift the tongue, there will be vocal cords. Lift the vocal cords, there will be epiglottis. Lift the epiglottis and you will see the vocal cords. Vocal cords can't be lifted guys, it was a mistake. So look over here, lift the epiglottis and you will see the vocal cords. Once you see the vocal cords, fix your visions to the vocal cords. Fix your visions on the vocal cords. Don't move your vision. And take the endotracheal tube. Take the endotracheal tube means, it doesn't mean that you have to look for the endotracheal tube. Where is the endotracheal tube? No. Fix your vision on the vocal cords. You need to tell, please give me the endotracheal tube to someone. Okay? Then take the endotracheal tube and under vision pass the endotracheal tube in between the vocal cords, right? It goes in between the vocal cords into the trachea. Your endotracheal intubation is done. Your endotracheal intubation is done. So remember guys, we are still talking about what? We are talking about the laryngoscope. We are talking about endotracheal intubation. Okay? So once you see the cords, you fix the vision and under vision you have to intubate the person. That is called as endotracheal intubation. That's the endotracheal intubation that we are talking about. Okay. Now guys, after doing an endotracheal intubation, how will you confirm you are in the trachea? Again, for it I'll give you a case so that you can remember it. Right. There was one of my junior. What he did, you know? He got a call. There was one of my junior. He joined the anesthesia department and it was his second month. In the second month, normally we give the juniors to perform the procedures and all. So it was his second month of anesthesia posting. So it was his first endotracheal. It was his first endotracheal intubation. So he was very much excited to do this endotracheal intubation. I was standing over there and I was just observing how is it doing the endotracheal intubation, right? So he took the laryngoscope, he put into the patient's mouth and he lifted the tongue. After lifting the tongue, he saw the vocal cords. He did a perfect laryngoscopy. After seeing the vocal cords, then what he did, you know? He told me, sir, I am able to see the vocal cords. Sir, I saw the vocal cords. He was excited to see the vocal cords and all. Okay? By that time, I knew that this guy will commit a mistake. Why? Because the rule is what? Once you see the vocal cords, fix your vision on the vocal cords. But he did not follow that basic rule. When you don't follow this basic rule, what will happen, guys? As he was new in intubation, was he pro in intubation? No. Doing the first laryngoscopy. If it's not under vision, if you move your vision from the vocal cords, your stability of the hand will be gone, right? When he told me that, sir, I am able to see the cords, I knew he will commit a mistake. What I did, I gave him the tube. I did not tell him anything. I gave him the tube. Now what he did, he took the endotracheal tube. Now he was trying to see for the cords, but the vocal cords were not visible. Vocal cords were not visible. Now the vision was gone. So what he did, he got panicked and he took the tube thinking that I saw the vocal cords. I had seen the vocal cords previously. So what he did, he took the endotracheal tube and passed the endotracheal tube blindly. He did not tell me he is passing blindly. He just passed the endotracheal tube blindly. Okay? But I knew that this guy will commit a mistake. Why? Because he had moved his vision. No. So after endotracheal intubation, I congratulated him that it's your first endotracheal intubation and now you have to give us party and all. This guy was a bit confused and a bit excited that his first endotracheal intubation is done. Confused, why? Why? Because he was not sure whether he is in the trachea or in the esophagus. He had done a blind intubation, right? So he did not tell me anything. After some time, what we noticed, there was fallen oxygen saturation of the patient. As the patient's saturation was falling, Now he called me, sir, patient saturation is falling. Normally after endotracheal intubation, it should never fall. If you are ventilating the trachea, it should never fall. There was fall in saturation. I knew 100% that is it in the esophagus, but I also have to first confirm it. How should I confirm? I can go for a screening method. What I did, I took a stethoscope, kept the bell of the stethoscope. I took the stethoscope, kept the bell of the stethoscope. I took the stethoscope. I kept the bell of the stethoscope on the patient's chest, right? And I told my junior to ventilate with ambu bag. As he was ventilating the patient through the ET tube only, no, ambu bag is connected to the ET tube. As he was ventilating the patient, I was trying to hear the air sounds near the chest, but I was not able to hear. Means what? I am not in the trachea. I took the bell. I have kept the bell on the epigastric region. Now when I kept the bell of the stethoscope on the epigastric region, I was able to hear the sounds, air sounds near the epigastric region. What does it mean? When he's pushing the air, I am able to hear the air sounds near the epigastric region. What does it mean? I am in the esophagus. So what did I do? I removed the tube and then I went for intubation and I did the endotracheal intubation. Okay? Guys, what mistake he has done over here? Remember the rule, if we follow, the mistakes won't happen. The rule is what? Once you see the vocal cords, fix your vision on the vocal cords and under vision pass the tube. But what mistake he has done? He was seeing the vocal cords, but he moved his vision from the vocal cords. And now the esophageal intubation happened. So guys, remember this was regarding what? Endotracheal intubation. So screening method is auscultatory method by stethoscope. But what is the confirmatory method? What is the method that confirms that you are in the trachea or not? The best confirmatory method is capnography. After intubating, you connect the endotracheal tube to a capnograph. You know what is a capnograph, guys? Capnograph is a device that measures the exhaled carbon dioxide. You connect the tube to a capnograph and you measure the exhaled carbon dioxide. So after intubation, if you do a capnograph, if you connect the device to a capnograph, if you connect the endotracheal tube to a capnograph, what will you see? You will get this capnograph, guys. You will get this capnograph. What is this capnograph? Just look over here. This is the exhale phase. This is the exhale phase of carbon dioxide, and this is the inhale phase. Okay? Once you are in the this is the normal capnograph, guys. This is the picture of normal capnograph. This is a picture of normal capnograph. Right? What is the EtCO2 value? EtCO2 is end-tidal carbon dioxide. The normal capnograph EtCO2 value is between 35 to 45 mm of Hg. When you are in the trachea, you will get this capnograph. The EtCO2 value will be 35 to 45 mm of Hg. Right? When you are in the trachea. Right? Now guys, imagine this is one form of capnograph. Okay? Now imagine after intubation, you get this kind of capnograph. This is called as flat line capnograph. This is called as what, guys? Flat line capnograph or EtCO2 value of 0. Flat line capnograph or EtCO2 value of 0. When do you see this flat line capnograph or EtCO2 value of 0? When you are in the esophagus. Very good. When you are in the esophagus. Yani ke esophageal intubation. In cases of esophageal intubation, you will see a flat line. Apart from esophageal, any other case? Imagine guys, I have intubated. I am having like 10 years of experience, 10, 12 years of experience working in anesthesia, not 12 years, 12 to 14 years of experience working as an anesthetist. I have done thousands of intubation, guys, thousands of intubation. Imagine I have done intubation. After doing intubation, I am 99% sure that I am in the vocal cords. Under vision only, I have passed the tube. 99.9% I am sure I am in the trachea only. But still I'll just connect the capnograph and I get a flat capnograph. I am sure I am in the trachea, but I am seeing a flat capnograph. Is it possible, guys, that you are in the trachea and getting a flat capnograph? Yes. Yes. Right? What is the possibility? You might be in the trachea and you might get a 0 capnograph value when the patient, immediately after intubation, if the patient develops cardiac arrest. If the patient develops cardiac arrest, you will see a flat capnograph. If there is no cardiac arrest, but still you are in the trachea and you are getting a capnograph value of 0, it also means that after intubation, if your endotracheal tube is obstructed, after intubation, if there is any obstruction in the endotracheal tube, will the oxygen go in? No. Will the carbon dioxide come out? No. So EtCO2 value will be 0. So in cases of obstructed ET tube, you will see a capnograph value of 0. You will see a capnograph value of 0. We are discussing about capnograph value of 0. In what all conditions you will see a capnograph value of 0? It is seen in esophageal intubation, cardiac arrest and obstructed tube. Okay? Next. Imagine, guys, after intubation, you get a capnograph like this. Is it normal, guys? Normal capnograph should look like this. Is it normal? It's not normal, sir. Why it is not normal? It looks like shark fin. It looks like the fins. It looks like the shark's fin. This is called as shark fin capnography. The third capnography that we are discussing is what, guys? This is shark fin capnography. Shark fin capnography. It is seen in what patient, guys? Shark fin pattern of capnograph is seen in what patient? It is seen in patients who's having bronchospasm. Who's having bronchospasm or COPD patient, you will see this. Okay, EtCO2 value will also come down. Okay, shark fin capnography is seen in bronchospasm and COPD. Next capnograph, just look over here, guys. After intubation, if you get this kind of capnograph value starting not from the, it is above the baseline, and basically this is called as high capnograph value, or the EtCO2 value is coming like 100. It is seen in what patient? Which patient? Okay, I'll give you a hint. Imagine we are using closed breathing circuit. In closed breathing circuit, you might get this kind of pattern. Why, sir, in closed breathing circuit you might get this kind of pattern? Come on. The heart of closed circuit is soda lime. If soda lime is there, carbon dioxide will be absorbed and normal capnograph will come. But if I use an exhausted soda lime, will the carbon dioxide be absorbed? No. If the carbon dioxide is not absorbed, the patient re-inhales his own carbon dioxide and his EtCO2 value will be high. So high capnograph value or capnograph value of 100 is seen in what patient, guys? It is seen in what patient? It is seen in exhausted soda lime case. If you use exhausted soda lime, you will see a high capnograph value. You will see a high capnograph value. The last thing in capnograph, the last capnograph that we need to know is, just look over here, guys. After intubation, if you get this kind of capnograph, or after intubation or during surgery, if you get this kind of capnograph. Actually, this was asked recently, guys. Just look over here. The picture was given of this capnograph and it was asked that during surgery, you look at the capnograph and you see this capnograph. What is the next best management? That was the question. We'll come to the question later. First, we need to discuss what is happening in this capnograph. Normally, the capnograph should be like this. But what is happening over here? There is a small notch coming. There is a small notch coming in the capnograph. What is this notch called as? This notch is called as what? It is called as Currar notch. Why do you see this Currar notch? Remember, the case was during surgery, suddenly the patient develops, suddenly you see the capnograph coming like this. It might happen, guys. Remember, before surgery, we are giving the patient muscle relaxant, yes or no? Before surgery means, sorry, we give any muscle relaxant to a patient. Any muscle relaxant means it could be atracurium or cis-atracurium. Imagine I have given atracurium to the patient. Your atracurium works for 30 minutes, yes or no? Okay? The surgeon has started the surgery. Surgeon is telling that 2 hours is the surgery time. You have given atracurium. Your atracurium works for 30 minutes. After 30 minutes, the patient will be out of the effect of atracurium. How will you come to know that the patient is out of the effect of atracurium? Atracurium causes muscle relaxation. If atracurium effect is gone, muscles will contract. Patient will either move, or before the patient moving, patient will start to breathe spontaneously. How will you come to know patient is breathing spontaneously? By looking at the capnograph. If the patient is breathing spontaneously, you will see this Currar notch. Currar notch is an indication of, return of spontaneous breathing. Return of spontaneous breathing. If you see this Currar notch, what will you do? What is the next step? That was asked. No. The next step, if you see a Currar notch, the next best step is what, guys? The next step is, come on, why is the Currar notch seen? Why? Because return of spontaneous breathing. Why is return of spontaneous breathing seen? Why? Because atracurium effect was gone. What is the next step? Give the dose of atracurium. Give the muscle relaxant. The next step is give muscle relaxant. That is regarding what? That is regarding this notch called as Currar notch. Is it clear, guys? This is regarding the capnography.